Hi, this is Dr. Greg Doerr, and welcome back to our monthly podcast for Bergen Chiropractic and Sports Rehabilitation Center. As always, with me is Dr. Doyle, and this is a special podcast because today we're actually introducing our new doctor. We have now started our physical therapy department in Bergen Chiropractic. It's been a bit of a hiatus since we've had physical therapy in the office. And Dr. Dani, welcome, first of all.
Thank you.
And why don't you tell us a little bit about your road getting to us? So let's start with some of your schooling, some of your early experience, and eventually the miserable process of meeting us.
Right. Okay, hello everyone. My name is Daniela Simancas. I go by Dr. Dani. So I went to school to Fairleigh Dickinson for biology, and then I went and got my doctorate for physical therapy at Rutgers, Newark. Right after that, due to some really good friends and connections, I was able to find Dr. Megan Doyle, who introduced me to the office, and now, thankfully, we're starting our new physical therapy program over here at Bergen Chiropractic.
So, in the process of all of this, I know you went through, what I like to call trench warfare. The process of actually going through the schooling to get yourself here, the testing that you have to go through to get yourself here. Why don't you let people know, because I always find it interesting how little people actually understand the education we go through. Like, everybody knows what an MD goes through.
Right.
They're always like, oh, an MD, OMD is like, okay, 4 years residency.
Right.
Everybody's like, so what was that, a year? Go to school for a year afterwards?
Yeah.
So why don't you just describe what your education process was?
Right. So for me, I went to Fairleigh Dickinson and I got my degree, my bachelor's degree in biology. And then during my senior year of schooling, when I was doing my undergraduate degree, I was working maybe like 35 hours a week, which half of them were for free, in order to get hours so that I could apply for physical therapy school. I was studying, taking my GRE, doing maybe like 20 credits a semester so that I can go straight into schooling right after my undergraduate degree. So in total, after your undergraduate degree, it's 3 additional years for 7 years in total. I got into Rutgers, which is one of the harder schools to get into. So for that, you require really good grades, of course, like GRE scores and, letters of recommendations and over 100 hours of volunteer work in many different settings, which I was able to do when I was a senior in college. And then after that, when I was in school during my DPT, I was able to, when I was in school during my DPT, I was then able to transition to become a doctor by, taking my exam and everything.
All right, so with the hours that you did, what were were they all in the same school? Was it, or not school, same clinics? Were they different clinics? And if they were different clinics, what were the areas that you seemed to gravitate towards?
I was in many different clinics before I was in PT school, and then during PT school, I would say the areas that I gravitate more towards are obviously sports injuries, pediatric work, and anything with the geriatric population regarding balance, everyday training, functional training. I'm good with that stuff.
Okay. Doc, do you have anything specifically that you would like to ask her about our education before I start going into some clinical stuff?
Education-wise, what was your favorite topic or condition to work with?
Anatomy. I got a 100 in anatomy class, a 100 in all of my tests, all of my homeworks, and I actually was an anatomy TA in DPT school, so that was my favorite class.
It's kind of making me feel really bad because I remember studying 4 days for my first anatomy lab test, and I got a B+ on it.
Ugh.
And I just remember going like, I don't get a B+ on anything. I don't get a B+ on a test I studied 4 days for. So congratulations on 100.
Thank you, guys.
All right. So we obviously spent a lot of time together over the last 8+ weeks.
Yes.
I've gotten to know you pretty well from the standpoint of your clinical prowess and where it is that you enjoy working, but obviously nobody else knows that. So let's start with body parts. Where do you feel like, oh, this is my bread and butter. This is where I live?
The knees, the shoulders, especially after surgery, the hips, the ankle, anything extremity-wise, I feel completely like it's my bread and butter.
Okay. Why don't you tell people about the psychotic sport that you like to do?
I love running. I'm a long-distance runner, and I'm currently training for 2 half marathons that are coming up in the next month and a half.
So I've desperately tried to explain to her that you do realize your sport was based on somebody dying, but she doesn't seem to listen to me at all. So now we have a runner. We've always been known in our office as taking care of lots of runners. We always joke with our runners. We're not here to insult you. I'm joking around. But the reality is, Dr. Doyle being a lacrosse player, myself being a soccer player, we believe in running for
A
10
reason.
meters, 15 meters, walk a little while, run again. You have this psychotic tendency of wanting to run continuously, which is why they invented cars. So can you explain to me why you've actually chosen to go against the evolution of transportation and decided to keep using your feet?
I would say, as somebody that never played sports growing up, I always struggled with like the strategy part of being athletic, and I don't have to do anything when I run other than run. I don't have to think. I don't have to do anything. It feels very easy to me, and the strain of it is not as strenuous to me as it is to most people.
Yeah, that's a mental imbalance.
Probably.
So we have a lot of running athletes. And I mean, not even just from the standpoint of obviously a lot of athletics deals with running to begin with, but we have a lot of marathoners. We have a lot of Ironman. We have triathletes. If you had, based on your experience, where is it that you would actually tell people, let's just say they're just starting out, what would be your recommendation to them just starting out as to how to stay healthy, how to get into that treatment program, how to keep themselves running well and not injuring themselves?
Strength train. That is the absolutely most important part about running, is strength training. I strength train about 3 times a week outside of my running. And it's what keeps you healthy. It's the only thing that teaches your body to, withstand the load that running puts on it.
That's an interesting one. Now, in this day and age, a lot of people, I've made this comment in a lot of my podcasts. Dr. Doyle and I have had these conversations on podcasts as well. It's like, when I was in high school in sports, like, we played soccer and we were track athletes, and they didn't let us near the weight room.
Yeah, right.
Obviously, that was a huge mistake, but as things developed and obviously things have gotten more important, you see cross-country kids are always in the weight room. What exercise in particular do you feel have best transitioned or assisted you in becoming a better runner?
I would say the number one exercises that I do myself and recommend for anybody that asks is anything that's really low in weight, high in repetition, and single-legged, because that's just what you're doing when you're running, so anything explosive. I like to do like single leg jumps. I like to go on top. I like to do like knee jumps with the drive. I like to make sure that my ankles are healthy and like strong, meaning like I train into dorsey, plantar, eversion, and inversion. And a lot of the strength training that I do as a runner is functional and very one-sided, because that's all I do when I run,
Excellent.
Yeah.
All right, now, you've been here for a while, at least in the capacity of meeting the office, learning what we do here. From the training perspective, what you've experienced here, what's been the biggest challenge for you?
I would say that you as a mentor have a lot of knowledge, and I guess it's a little bit intimidating to try and match the expectations of what people like have when they come here.
Well, Dr. Doyle taught me everything I know, so we're safe from that standpoint. Is there therapies that we're doing here that you really didn't have a lot of experience with before?
Taping.
Yeah.
Taping has been truly something that I now stand with my entire chest for. But prior to this, and learning and seeing the effect that it has on patients, and actually running on like a sprained ankle for 4 miles at a really good pace because you tape me up. I mean, it can be really life-changing for patients, especially like athletes that just like need a quick fix and they need to get on there in the field and they have no other options but to get on the field. Like, I love that about it. I was like, wow, like this is something that can be really used as a modality, because you're not over here saying that like tape heals anybody. You know what I'm saying? You're over here saying that tape can be used additionally to everything else that we do to support the body, and it works like magic. So
it's a way of treating the patient when they leave the office.
There you go.
So as you've also seen, and people are coming in, you're starting to see athletes well past running. You're starting to see everything from, we have our football players, we have our soccer players, we have our volleyball players, we have everything like, you're starting to see the post-surgical starting to come into our office. I know we just had one the other day that you got to evaluate. If there is an age group or a sports group that you're not used to, like you're a runner, where do you seem to be gravitating towards? What are you seeing that you're like, kind of like this population, they're fun?
I would say, although I really like the sports aspect of PT, because, I'm a physical therapist, you have to. I really gravitated towards the geriatric community more, like during my earlier training years, and then the older that I got and the closer that I got to like actually working in the clinic, and especially in here since we have so many athletes, I would say like the sports aspect of it and just like the really cool like therapy about it, and like the really like weird exercises that we do to kind of target many different things all at once, but still be specific to like our final goal, like functionally. You know what I'm saying?
Now, I know this because we've had private conversations about it regarding balanced vestibular training, things along those lines. It is a hot topic. All right. So now I'm going to actually put you on the spot. It is something that, quite frankly, Dr. Doyle and myself, we look, if we have a post-surgical case, we book extra time for us to take care of that rehab-wise. That was honestly one of the largest aspects of we want you here to, and as you know, we believe in a very team approach as to how we take care of people to begin with. How would you incorporate, because we haven't really incorporated that tremendously into our practice, how do you want to incorporate that balance, that vestibular training into here so that we actually have an expanded aspect of what we do?
Absolutely. So I feel like vestibular and anything balance related and physical therapy go really well hand in hand. And myself, as somebody who has a big interest in the geriatric community, I've had a lot of exposure to it. I mean, in every single clinic that I've worked at, by the end of it, every single like old person that walks through the door, everybody's looking at me because they know I want them, you know? And then in terms of the therapy that we do here in this room as well as in the other rehab room, I mean, we have everything that we need to do rehab therapy. All I need to do is put stuff on the floor and ask the patient to go and try to cross it while giving them cues, while verbally trying to communicate with them, because cognitive affects vestibular as well. You know, I was working with a patient earlier this week by placing different targets on the wall while having her stand still and just having her do like different saccades so that her vestibular system can be affected. All of those exercises can be done by me. It can be prescribed by you guys.
All right, so again, I feel bad about this. The thing that we haven't had in the office lately, and largely because I was using it myself at home lately, I think the blaze pads, it's time for them to come back in.
Yeah.
So that gives you the ability to do the cognitive and visual cues with light up and reaction time.
Absolutely.
So we will definitely bring that back for you.
Yeah.
And let you start having a lot more fun with that stuff and playing with it.
Beautiful.
Is there, let's say, you've been here already. We're putting our office on the spot. If there is a piece of equipment that you're saying, you know, again, it doesn't have to be, you know, $100,000 isokinetic machines, but if there was something that you said, geez, I think we should probably look to try and get this into the office, is there something here that you're going like,
The only thing that I want is probably just weights. That's it. Other than that, I feel like I was able to not only maneuver around what I have, but also at the other office, although we don't have the same things, you have enough. And you have a lot of like weird gadgets and stuff that can be used to treat patients effectively. Like I was like, hi, do we have a pulley in here by any chance? It was literally like bagged, wrapped. And she was like, probably we do. And we did in fact have one. So we're just lacking weights. That's it. It's just weights.
What type of weights do you think are necessary for what we need?
You know, I feel like in terms of duality and having because you know, I use weights in terms of like loading attending and stuff like that. In the past, I have used weights that have different settings that you change the weight and then you pull out as many different weights, and it goes up to like 55 pounds per thing, but it's very cost effective. You have like, you know, the option of having like 10 pounds, 15 pounds, 20 pounds, 50 pounds, and up to 100 if you're carrying both at the same time.
I have those at home. They go to 90 pounds.
This guy.
I have not lifted a 90-pound dumbbell in a very long time.
Oh, there's music to my ear. I love that.
No, and I'm trying to remember the names of what those dumbbells were.
Bowflex.
Bowflex,
I definitely think had one. There was I think
they're
it might have
great,
been
and they're very good for space too, because they're compact.
The only thing that I can say, I don't know if you've ever used those.
Yeah.
But the only thing that I ever found was they sometimes got a little bulky.
Yeah.
For sure.
From a lifting standpoint, but I mean, again, I'm sure they have other ones out there that we can switch over that are not quite as bulky as Bowflex, because we don't need 90-pound dumbbells.
Yeah.
If somebody dropped a 90-pound dumbbell on this floor,
yeah, that probably wouldn't be fun.
But we find the laundry really quickly.
Yeah, right.
And in the other office, I think we'd find the periodontist really quickly too.
Yeah, but other than that, I mean, I was working with a kid yesterday. You would have loved to work with him. To be honest, he was a runner and he had hamstring tendinopathy, and I was finding just every way to like load it. I was having him do like what's it called, RDLs with the gold band, because I was like, you're really strong, man. I don't got anything else for you. He's like,
Gold band's on a weighted bar.
he's doing like, yeah, exactly. I was doing that. I had him do like, bridges on the, what's it called, on the foam roller, where he's like, going back and forth without losing that hamstring contraction. Just figured it out. But you have enough stuff here, trust me.
Tell me from a standpoint of what you've gone through in the training. We've pretty much hit all the body parts. We've hit soft tissue, we've hit rehab, we've hit taping. Is there something in particular that you're saying, I actually want to learn more on this topic from us?
I mean, I really could take 100 hours of classes from you guys on how to treat the neck and the spine. I feel like I know how to treat the neck and the spine, but I don't feel like I know enough, You guys are so particular. Even like when I'm looking at your notes, like in terms of like diagnoses and everything that's structural versus like muscular, like physical therapists, like we don't get so in depth about the spine as you guys do. Like we learn everything that we need to learn about like every carpal bone in the hand, but other than that, the neck and the spine is just very, very like vague to us when we were in school.
Now, I'm going to be annoying here, as if that's a surprise. I want you to tell me, I'm going to go body part by body part. I want you to tell me your favorite thing to treat individually in that body part. I want you to literally give me the diagnosis.
Okay.
So let's go with one of your favorites. Go shoulder.
Impingement.
Okay. Elbow.
Ooh, tendinopathy.
All right.
Outer. Lateral.
Lateral.
Yep.
Wrist. Hand. We'll put them together.
Anything like TFCC.
Okay.
You just have to distract them.
Neck.
I don't like treating the neck, but I would say anything muscular regarding like the upper traps or like the suboccipitals, I'm pretty good at.
Headaches.
No.
That's why we have us.
Yeah, right. Exactly.
Let's go with low back.
Low back. Fun wise, a spondylosis. Have you treated that
What's
for like a gymnast?
Oh, spondylolisthesis.
Not like a spondylol.
Lysis.
Yeah, it wasn't.
Yeah.
It didn't move. Yeah.
Oh.
It was fun.
Well,
She was a little girl. She was like 7.
Spondylolysis can be a pain in the butt rehab.
It was literally.
Okay, that would definitely not have been
That's
my
the
choice there.
funnest one that I've ever treated because she was 6 and she was a gymnast. Wait,
Yeah.
7. I would say anything regarding the glute med is easy to treat.
Okay. Knee.
Patellar tendinopathy, TFCP. Done.
Ankle.
Ankle sprain, bread and butter.
Love those.
First thing we learn in PT school.
Foot.
I would say like whenever patients have like issues with the metatarsals, like the ligaments in there, you just have to spread the toes out and it's like magic.
All right. So basically what we're doing is we're seeing everything that you love is what we do, which is great.
Awesome.
So all we're doing is actually increasing our patient's ability to get extra services from a skilled provider and to have actually more individual attention than obviously Dr. Doyle and I can give on our own. Not to mention, it's great, in my opinion, has always been the more eyes you have on a topic, the more eyes you have on a patient,
Absolutely.
the better off you are, and the less likely you are to actually miss something.
Absolutely.
So, Dr. Dani, welcome.
Thank you.
She is now the person in charge at Bergen Spine and Sports Rehabilitation Center, our physical therapy company, whereas Dr. Doyle and I will be heading up Bergen Chiropractic. That being said, it'll be a wonderful team together.
Very excited.
We look forward to years of service for all of our patients and continued excellent outcomes.
Very excited.
So, thank you and welcome.
Thank you very much.